see if I can do this. It's definitely not the ideal scenario. So probably.
What about Hexes?
It's,
Put it in the pocket.
and that could go in the pocket. It's just a matter of can it be picked up. But first of all, which one is that? Let's see. It's not even labeled. Okay, so let's see which one that is. Okay, do a test talk.
Hello. Especially from you, because we've shared a few patients. We've had some complex ones that you've taken care of for me. The ones I couldn't get into the heart. I remember one case we had an interrupted IVC, and I was debating transhepatic approach, but his INR was too high, and then he was ablated surgically, and the patient did really well. And he's doing pretty good, yeah. Yeah, I'm following him for a while, and he has some anomalous coronaries too that needed to be taken care of. So everybody is pretty far behind the mapping and some pictures over there. You may have to just squint to take a look at them. But we'll make this very informal and interactive. And if you find it a little complex, just raise your hand, and then I'll try to slow down and walk you through these. But the main purpose of this is to talk about some of the few things that we've been doing, advancing the field of electrophysiology. So the talk will be divided essentially into three parts. First part will be what we call as flow reduction techniques. The second will be talking about mapping complex arrhythmias. And the third will be some case discussions that we'll go through. So what are the advantages of fluoroless technique or using any fluoroscopy? I learned it from my personal experience where I started having back pain. I remember 4 years when I came into, I already started over here at South, and then one day I just had this severe back pain, and we were ablating right, left, and center. So much so that some of the staff members are still there from 7 or 8 years ago, but so much so that they had to actually pause my case. And one of the nurses was so nice, and I don't know, Amber is here? Does she remember this? Do you remember this? One of the nurses actually was so nice enough that they got an appointment for a chiropractor for me for that day at 11 o'clock. And I've never been to a chiropractor before. I'm not going to talk about how that worked out, but since then I've cut down the use. So I don't try not to wear lead in most of the cases. It's not only about radiation exposure; it's about back stress, discomfort, and then knowing the real thing. If you're going to look at X-ray, X-ray is a two-dimensional thing, and these are 3 or 4-dimensional structures that you're playing with. And then if you just rely on X-rays, a lot of times you don't see what you're looking for. So let's start with the first step, which is transseptal catheterization as we're moving towards for an AF ablation. The keys over there is utilizing long sheets so you don't get caught up in the vasculature in the femoral area, and then utilizing ice. And I'll walk you through some of the ice views that are important. So this is a quick video of how we do it. I'm going to pause it if it moves too fast. So what we do is we essentially put a wire up in the superior vena cava. So now our intracardiac echo catheter is sitting in the right atrium. So imagine me as an intracardiac echo, right? And then the beams of the ultrasound go spread out like this. Everybody with me? All right, so if I want to look up in the SVC, if I'm sitting in the right atrium, if I want to look up in the SVC, what I do, I tilt it up like that. So I do a posterior tilt. Everybody with me? So when you do a posterior tilt, you can look up in the SVC, and this is what we're doing. This is a wire up at the SVC, and this is, okay, so let's go back. This is the wire up the SVC, and you're going to see the sheath being advanced over here. So the sheath getting advanced here, right? And then with the dilator, then the wire comes out. The next step is we advance our needle. A needle never obviously comes out of the sheath at this time. This is a live case we did for one of our meetings that we do. And then we're looking at our intracardiac echo pictures. So it's coming down from the superior vena cava all the way to the fossa. So I'm going to pause over here for a second, so I can walk you through some of the views. This is the needle getting advanced. So this is the needle and the sheath coming down the fossa. So let's pause it over here. So if I'm the intracardiac echo and I'm looking over here, so my beam was in the superior vena cava. Once I reach at the septum, I let go of that superior beam. Now I'm looking at it straight. So the first structure that I see if I'm looking at it straight, if I'm sitting in the right atrium, is the tricuspid valve. That's called the home view. All right? And then as I start rotating, the first view that I'm going to get is what? Anyone wants to pick up? Aorta. Kristen knows that. She's smiling. So aorta, right? Then I move more. Then I see what side veins? Left-sided veins. Everybody with me? Then I move more. I see the posterior wall. Then I move more. Then I'll see the right-sided veins. So that's exactly what's going on over here. In a pulmonary vein isolation procedure with RF, you don't want to do a puncture at the level of the mitral valve and the left atrial appendage. We like to do a puncture when I can see the pulmonary vein. So it's so critical to know where you want to puncture the septum. So that's why utilization of intracardiac echo is so important. We don't use, that's why we hardly use any fluoroscopy for this. So you can see my needle and the sheath falling down. This is the aorta in view, as you can see. So I'm going to move the ice a little bit more posterior. Where can you see my needle is coming down. Down, you can see the appendage in view over here. Now I'm at the fossa, and here I can see the pulmonary veins. So this is where you see the pulmonary veins. That's where we'll do the puncture. Now this is the aortic valve, which was much anterior. This is the left pulmonary veins. When I see the pulmonary veins, that's where I do the puncture. So pretty straightforward. As you do the puncture, you advance the sheath, and now you're in the left atrium. You're fully anticoagulated, then you can start with your second step of a pulmonary vein isolation procedure, which is coronary sinus catheter placement. These catheters are visualized under 3D mapping, so pretty easy to do. You don't have to utilize any fluoroscopy for this. I'm going up the IVC, going up into the right atrium. What we utilize is essentially the intracardiac signals. Once I'm in the atrium, I can start seeing the atrial signals. Then I drop it into the valve. I see ventricular signals. Then you usually clock it. And if you clock it, this is the LAO view. The only structure which you can get to the left at this level is coronary sinus. So you see an A and a V signal, and you're sitting in the coronary sinus. It literally takes about 3 seconds to do. So once this is done, we know we have some signals and some mapping reference in the left atrium. This is the home view that I was talking to you about. In cardiac echo, you have to recognize that for left atrial geometry creation. These are the pulmonary veins. So again, home view, tricuspid valve, move a little bit, aortic valve, move a little bit, mitral valve, left atrial appendage, move more posterior, pulmonary veins, then posterior wall, and then right-sided. These are the right-sided pulmonary veins that you can clearly see. This is an example of how we do the left atrial map. In this particular case, I'm using a circular catheter with multiple poles in it. And this is the left atrial geometry. Just to get oriented to these colors a little bit, purple means, and this is the ice picture going at the same time, purple means normal tissue, green and gray means abnormal tissue, or where you get into the pulmonary veins where the voltage is lower. You can easily see how the catheter is going inside the pulmonary veins. You mark the antrum or os of these veins. This jumped into the right superior pulmonary vein, and it's correlating with your 3D mapping right here. And then you're trying to get into the left inferior pulmonary vein. You mark the os over here. So you don't want to burn inside, or you don't want to ablate inside the pulmonary veins because of the risk of PV stenosis. And this is how we create a left atrial map. And once we have done the left atrial map, our next step is ice utilization during ablation. So usually we advance our contact sensing ablation catheter. The two different companies which we have available. As you can see, the catheter is touching the tissue and applying heat energy. The intracardiacs are the example where you can actually see that I'm pacing while ablating. And when I lose capture, I know that the lesion is good, and I stop over there. So this is, and then there's some other examples of how you can utilize the intracardiac echo. So this is the left inferior pulmonary vein. Let's play the video one more time. You can see the sheet sitting here, catheter sitting here. You can identify the catheter contact. And as you're ablating, you can see the tissue turn bright white. So that's another example. Sometimes the contact force is not enough. Why is that? Because these contact sensing mechanisms have either a spring mechanism in there or optical wires in them, which can give up during long procedures. And sometimes you may not be touching the tissue, and you'll still display force. So that's why looking at all the parameters when you're doing ablation is extremely important to recognize that you're actually touching your tissue and doing something. This is a direct feedback from the tissue. And that's how we're going to get low recurrence rate, that if you actually create a lesion in there and identify that. So intracardiac echo helps identify that. This is another example when I'm ablating right outside the right inferior pulmonary vein. You can see this is the fluid coming out. I'm ablating, and Rick can appreciate that. You can see the tissue getting brighter, right, as you ablate, obviously. And then if it becomes too bright, too quick, obviously you stop, because you know you can have a steam pop or perforation in there. This is an example of a very large left atrium, and we're going towards the left pulmonary veins. My sheath ends up here. I have to rely on my ablation length, and you can see I was burning at the ridge between the left atrial appendage and the pulmonary vein, one of the most trickiest area, and then I jumped into the left inferior pulmonary vein as it comes out into the, so our experience with this fluoralist technique is greater than 500 cases over the last 5 years I've done with a zero pericardial tamponade, zero stroke. And the big thing is that we do more than 90% first pass isolation. What does that mean? Well, when we're going around the pulmonary veins and creating these lesions, what you want to do is your first lesion needs to be your best lesion. If you keep going back and forth to that area, what you end up doing is creating edema. And a lot of times, those are the veins which reconnect. So it's key that when you apply heat energy, you stay there long enough, make sure all the parameters are met from contact force, from ice utilization, and signal reduction before you move to the next spot. So for us, when we do the first pass around, most of the times when we finish, the veins are electrically isolated, and that's a good endpoint. Now, in some remote cases, there are some connections which are deep into the veins that you won't be able to get first pass isolation, and then you have to go in, move around to get that. And those are the kind of cases which tend to recur. So that's why it's important to try to do that. So this was just an introduction of how we have worked towards reducing fluoroscopy using intracardiac echo. Let's come to the fun part, which is the high definition activation mapping. So these are some of the basics of electrophysiology. And you need to understand that a little bit to understand what we do actually in the lab. What we do essentially when we are trying to understand if a patient comes with a complex arrhythmia or complex tachycardia, what we're trying to understand is where is that tachycardia coming from? And we rely a lot on our electrograms. So when we put a catheter, whichever kind catheter it is, with multiple poles or single pole, we're looking at the direction of electricity that that catheter is seeing. So let's say if this is a catheter, and then I have electrodes over here, I'm gonna see what direction the vector is coming and activating that catheter. Does that make sense? And that's called activation mapping. Now, there are two basics of activation mapping. One of them is unipolar. What does unipolar mean? The unipolar means is that if there's a catheter and it has an electrode in there, right? This electrode has a reference to a far distant electrode to get a full major electrical field created. So an example of indifferent electrode. So what we do is typically take something called a Wilson's terminal or put a catheter in the IVC to create a big electrical field. Now, this is a point in the heart which is causing the tachycardia, correct? If I put my catheter over here, right, and my electrode is sitting right on there, on the spot, and my indifferent electrode is far away, what's going to happen? All the forces are going to go from this point to the other point, right? Because this is the tachycardia, this is the area which is firing, correct? So all the EGMs will be going away from it. Does that make sense? So whenever that happens, you see a very deep QS wave on the electrogram, because all the forces are going away from the tip electrode. Does that make sense? No, everybody's lost here. So let me explain this again. All right, so this is the heart. Let's say this is the coronary sinus. I have a foci over here, which is an atrial focus, which is firing, right? It's just firing. It's causing the heart to beat at 200 times a minute. Everybody gets it? Now, I go with my mapping catheter in there, and I touch that area, and I'm right next to it. If I'm right next to it, all the electrical circuit is going to go away from it, right? Because this is the area which is firing. Everybody with me with that? So if I'm at the right area, since all the electricity is going from it, you're going to see a deep QS wave on the electrogram. If I'm not there, if I'm away from there, then sometimes you will see an R wave and then an S wave, right? That's why we look for a deep QS wave on a unipolar EGM. So that's, yes, sir. Yeah, a stable electrical rhythm. Yeah.
Where, at least I think it is a good answer. But the other one, I suspect you're going to get to, is atrial reentry tachycardia. This is not atrial reentry tachycardia.
No, this is a foci firing.
This is an automatic atrial tachycardia with a foci. And would it be correct to say that it's not very common?
Atrial foci atrial tachycardias are relatively common, but most of the tachycardias we run into are reentrant tachycardias. But what I was going through is a basic mechanism. Even in the reentrant tachycardia, we try to get the electrograms in a unipolar and bipolar to understand the directionality of that circuit.
What I'm doing is engaging with what you recommended, to have an open conversation.
Okay, good. So let's understand this unipolar, and then I'll walk through the reentrant circuit, and that's what most of the circuits are, and you're correct on that. So that's the advantage of a unipolar EGM, right? However, what are the disadvantages? When you have a big antenna, right? This big an antenna, in which your main electrode is sitting here, and indifferent electrode, you get all kinds of signals in there. So imagine a radio transmitter which has a big transmitter, you're going to get a lot of noise. So those are some of the disadvantages that we have to worry about, the near and the far field signals, and careful filtering due to low signal noise. So for the people who are in the EP lab, it's extremely important to get unipolar signals for us to get an idea. However, you have to work very diligently to reduce the noise. Everybody with me? Now, the other one which we mostly use are the bipolar electrograms, and that has been specifically designed to understand really the local pattern of activation. And what happens in bipolar is we take one pole and we take a second pole, and you take a unipolar EGM from here and a unipolar EGM from here, and take the difference in the two to understand what the local activation pattern is in that area of the two. So for example, if the unipole is D and unipole is 2, the sum of that, the difference, if this is going in this direction, this is going in this direction, the sum of them comes out to be a bipolar AGM. And in short, when there's a bipolar electrogram for that specific catheter, it doesn't help us in directionality, but it helps us in activation timing. So if I have a bipolar EGM, which is really early as compared to, let's say, surface QRS or a reference, then I can say that I'm at a very good spot. So to summarize, unipolar is for directionality, and bipolar signals is for timing. It makes sense for everybody? Okay, so local timing of the near field, highlight sharp signal, that's the advantages, and disadvantages, electrode sizing and spacing. So once I've talked about this and not making it too complex for you, what is the problem? The problem is when we start mapping these complex arrhythmias, even these unipolar and bipolar electrograms are not sufficient enough for us. And the reason for that is the activation wavefront, direction of the activation wavefront. So let's look at this example. And I know people will start yawning over here for a second, but let me walk through this real quick and go to the real part, because this is important to understand. So if my catheter is sitting like this in the heart and the electrical signal is like this, I will get a really sharp signal, okay? This is on the bipolar. And if I'm very close to the circuit, this will be very early to the reference. And it's a beautiful spot, and I ablate, and life goes on. However, if I put my electrode in perpendicular, because this bipole and this bipole gets activated by the same front, the difference of that comes out to be negative. So I'm not actually able to see any signal at all, or a abnormal signal. So I'm at the same spot, I'm at the good spot, but just my directionality of the catheter is telling me that I'm at a bad spot. So that led to the development of a different kind of catheter, and that's where I'm going with this talk. It's a limitation of bipolar recordings. What if we have catheters located in both directions, okay? So this one will have activation going in this pattern, but if I have another catheter perpendicular to it, it will go in this. And what if I can create an algorithm which gives me a summation of these two? And then it'll be able to identify accurately where my activation is. This catheter became available to us in the market. It's called the HD grid mapping catheter based on this. Now this concept came about 15 or 20 years ago from Mark Josephson's lab, but it took a long time for these catheters to develop. So it's a first of its kind electrode configuration where you actually have 3-3 spacing, and you have activation in two axis, so you can identify which direction the electrical wave is actually flowing in. And this is the example of the HD grid catheter. It has changed the paradigm for mapping for us as compared to standard catheters that we've been using, and made life easy for us. And I'll show you some examples for that. So that you understand. These are the typical catheters. So you see the waveform going in this direction, right? If the waveform is going direction, a standard bipole catheter, a pentaray catheter, which we've been using for a long time, and an HD catheter, you see electrograms being activated properly because the waveform, the bipole between this and this will identify the waveform accurately. However, if I move the catheter, in the other direction, and I'll pause it here. about that. This is one activation pattern. All of them get good EGM. However, if you move the catheter like this, you'll see if the catheter is placed like this, no EGM is recorded here because of the activation pattern. The D2 and D3 got activated like this. The summation of that came out to be negative, and you're not able to see it. Similarly, in a pen array catheter also, because you're recording here and here, you're not able to see this EGM. However, if you have a grid catheter, because you can identify in this direction and this direction as well and takes a summation of that, you're able to get an EGM. So it changes. And a lot of times we used to compensate for that by just moving the catheter around and to get EGMs, which takes more time. And with this, it actually shortens the procedure quite a bit. Everybody with me on this? So this led to the concept of what is called bipolar blindness. So let's look at this concept. And it's actually a very new concept over the last 6 months. And I'm sorry, it's a complex talk, but we do complex ablation, and I see my lab out here. So this is an example of a patient who has had previous pulmonary vein isolation procedure. I'll walk you through this. The purple means normal tissue. The gray means it has been ablated before, so there's no electrical circuit flowing in there. Got it? This patient came back with a re-entrant circuit because one of the lines which was created was not complete. Fair enough? And a lot of times when these patients come back with this flutter, these flutters are even more symptomatic than the true atrial fibrillation because the atrium is moving a little slower, the ventricular conduction is faster. Okay? And then when it's faster, people feel it more. So to map it, we put originally when we saw that all this area was gray, but when we put a grid catheter in this area, we saw these electrograms. Okay? You can see these electrograms. That means there is live tissue in that circuit. Fair enough? Everybody with me? And you can see that in the gray area, you can see the red patches. The red patches are live tissue in dead tissue. And that live tissue is creating re-entry circuit, as we were talking, which is the most common mechanism of arrhythmias, as we talked about, which is causing the flutter to happen in this patient. However, when I put my ablation catheter over there, which is a typical bipolar catheter single lining, I see no electrograms at all. So that's the concept of bipolar blindness. So I put my standard catheter, I see nothing. I put a grid catheter, I see signal. Then I put my ablation catheter and I pace. When I pace, I'm capturing CS. So when I'm pacing with capture, that means it is live tissue or dead tissue? Live tissue. So that means that this information was inaccurate that we've been relying on for years and years and years. And the accurate information is provided by a catheter which can measure electrograms in different direction. And then I'll show you an example of this in some of the cases ahead. So in summary, the advisor grid helps us identify variability in electrogram characteristics. It gives us directional information by taking direction in this and giving us summation. And it's usually used in conjunction with a duplicate algorithm to display highest data on the map. So let's go to the fun stuff, which is the case studies. You ready for some questions, guys? I'm going to ask you questions on this. You ready, team? All right. Okay, I got a bunch of coffee out here for people. This is a 71-year-old male with history of a prior pulmonary vein isolation. Pulmonary vein isolation means that we go around the pulmonary veins, apply heat energy, make sure that the veins are quiet. That is the cornerstone for AF ablation. This was discovered in 1995 by Hasegawa, where he found out that these pulmonary veins were the main triggers for this. So that's the cornerstone. So this patient has been ablated before. They also went up and did a posterior wall isolation, which is the area between the right-sided pulmonary veins and the left-sided pulmonary veins. And unfortunately, he presented with a atrial flutter, quite symptomatic. I didn't show you the EKG to save some time, but this is extensive time was spent on mapping of these tachycardias. And so let me walk you through some of these colors. In a lot of these cases, we have to do biatrial mapping, and a lot of these patients are sick, so we got to move very quick in them. This is the right atrium connected to the left atrium, and it's more than looks over here, so there's a lot of information here, right? And then you're looking at it in an anterior view, so you're looking at it from front, so you can see the SVC, IVC, and this is where the cavernous-tricuspid isthmus, CTI, tricuspid valve sits here. This is the septum connecting the right atrium to the left atrium anteriorly. Everybody with me? Okay. And then you're looking at it from a kind of a lateral view where you can see the mitral valve, the tricuspid valve, right atrial appendage, left atrial appendage, and you can see looking at it from kind of underneath. All right. So the colors, what do they mean? The purple means late. So these are the milliseconds. This is an activation map. We put the grid catheter in the right atrium, left atrium, and took points. And those points are bipolar or grid points in different direction to look for activation. Purple means late, white means early. So the mechanism of a reentrant tachycardia, which is the commonest tachycardia, Dr. Mavroudis, as you were talking to about, is usually there is a channel of slow conduction where the early will meet the late. Okay? So there is a slow conduction area, whether because of a scar or whatnot, which will cause a critical isthmus, and then an early activation here. Then it goes around the whole chamber, depending on how big the circuit is, comes around, which is the late part, and then the early usually meets the late in that critical isthmus. And the way you break those circuits or reentrant tachycardia is applying heat energy on those critical isthmus to break the tachycardia, because that's the abnormal tissue which is generating that circuit. Everybody with me? That's the simplest I can explain. Yeah.
That is, when you have that circuit or that slow conduction, waveform comes around on the right atrial appendage. Waveform. Maestro? When the waveform starts in the right atrial appendage and comes around in a normal fashion to the area of the isthmus, namely the atrial, the coronary sinus and the tricuspid valve, there's an area there that it slows up, just like exactly the way you said. It slows up, and then that continues after it slows up to go around. So I would look at that as an area of slow conduction, but you're transforming it. Here's what I think is the lesson. You're transforming an area of slow conduction into an area of no conduction. And when there's no conduction, then that waveform just goes along without being slowed up. I tried to explain that to surgeons. I'm not sure they get it. Maybe you'll have a better course on it. But I've tried to do this in my entire career about this. I'm not so sure I'm getting to it, but it gets to me. So you're transferring an area of slow conduction into an area of no conduction. Does that make sense?
It does. It does. And then...
Or am I just being kind?
I mean, there's different ways to explain this, but yeah, that's one way to do this. But the macro reentrant circuit is a little bit more complex than that, and there's certain criteria that you have to meet to call it a macro reentrant circuit. And without going into too many details of that, and if you want references for that, that's Dr. Waldo described it. He's from a Cleveland hospital in the early 1980s. There's certain criteria which you have to meet to call it a macro reentrant circuit. But the main concept is exactly as he described. So there's a critical channel, critical isthmus, where there's slow conduction, and then after that an area of no conduction, and then it speeds up, which causes this. And the way you identify that is identifying those channels of slower conduction, and then you look at activation map where you have the whole tachycardia cycle length, and then you look at also entrainment maneuvers. What entrainment means is when you're close to the critical isthmus, there's certain criteria you have to meet to call it, and I didn't want to go into that in too much detail. There's certain criteria that you have to meet to call it as the critical isthmus, and one of them being the post-pacing interval. So when you're at a good spot, when you pace in the area, the EKG will have no fusion, which means the EKG will capture the same way as the tachycardia was going, number one. Number two, your post-pacing interval, when you pace, when you finish, it will be the equal or close to equal to the actual tachycardia cycle length that was going. So for me to call this macro reentrant based on this, let's say if I have a critical circuit over here, and I put my catheter here, and if I pace here, when the cycle length comes back after pacing, it will be the same the post-pacing interval of this area will be the same as the tachycardia cycle length. And then there should be no fusion. And there's got a couple other criterias, but they'll be a little bit too complex for this talk. Anyhow, so going back to this, this is another way to map these reentrant tachycardia, which we prefer, because when we pace these circuits, a lot of them get disrupted. And you don't want to disrupt them. You want to actually map the clinical tachycardia of the patient. So the white is the early spot, red is the purple is the latest spot, and you can see there's an area where the white is actually meeting the purple in this area. So you have identified the whole tachycardia, which is involving the right atrium and the left atrium, and the white is meeting the purple. So the critical isthmus sits around here. But what is extremely interesting over here is you will see, which you're not able to identify in a standard mapping, is this. So this is called a propagation map. Okay. So what does the propagation map shows? It's essentially showing area of fast conduction, as Dr. Mavru just pointed out. See, it's going very fast through this area, very fast through the right atrial appendage. But as it moves around, there's an area of very slow conduction over here in this small part. See that? And then, as you can see, there's an area of functional block here. So what you see is this line doesn't meet this line. So this was an area which was already almost dead, but there was only a small critical channel over here which is conducting. You see over here? And you're not able to identify this unless you use the right catheter. If you put a bipolar catheter here, standard ablation, you're never going to see it. If you even put a pen array over here, it will not be able to identify this functional block. Now, I can tell you 4 years ago when I was using that pen array or any other catheter, I would have ended doing a full ablation line from here to here because I would not have been able to identify this functional block. But since I identified that functional block, this area is already blocked. I don't have to give any ablation over here. And what you will see is it's kind of magic over here. And this is called the speckle map. And you can see over voltage how the activation happens, breaks through this area and then goes around. For how many it does looks like Wiggles and not making sense? Just be honest. Oh, there you go. There's an EP in the room. So I'll walk you through again. All right, this is a propagation map, which is the purple area. See, it's going very rapidly through the right atrium, right atrial appendage. It's going very rapidly through the left atrial appendage. Posterior wall is already blocked from the previous, but the area where it slows down is this area. If you look at it carefully, it slowly conducts and breaks through over here. Okay? So once you identify that, the next step is pretty easy. You put your ablation catheter in this here. I can tell you 4 years ago, I would have had to do a full line. I did 3 ablation lesions, and tachycardia terminates right away. This is the flutter running around at about 250 beats per minute. Lesion, boom, boom, sinus rhythm. So you spend a little bit more time with the mapping catheter, very little time with the ablation catheter. And then you go on and check this line and make sure this line is blocked, and you're done for the day. So some of the tools, utilizing these newer tools make life easy for us and for everybody. And then you're able to identify that because of the kind of catheter you use. And this is an example of functional block, okay? This is important. So this is my grid catheter sitting in this area, okay? So what you can see is 2 signals. The coronary sinus catheter over here has only 1 signal. See, 1 signal, and A and then a V, right? But in a grid signal in the area, I see 2 signals, 1 here and 1 here, for each cycle length. Everybody with me? Or too complicated? Okay. All right, some of them with me. So there are 2 signals for every 1 signal, 2 signals for every 1 signal. This is called functional line of block. That means 1 activation is from here, 1 activation is from here, and this. But this area, there was slow conduction throughout this. So I was able to find an area where there was continuous activity throughout the whole cycle length, and that's the area to burn. And are you going to be able to find it if you put a standard bipolar catheter? No. Are you going to be able to find it if you put a lasso or a circular catheter? No. Are you going to be able to find it with a pen array catheter? Possibly, if you have multiple electrodes which are getting information in different direction. All right, and then the other advantage of that is obviously you can reduce the ventricular thing. So let's go to case 2. I've got about 8 minutes left on this. This is a patient with a prosthetic mitral valve replacement, dual chamber pacemaker, RV pacing, extremely symptomatic from heart failure because of the flutter. Again, this is an example of flutter. You can see the coronary sinus 2-to-1 conduction, right? Coronary sinus for each ventricular beat, right? So this is a slightly slower cycle length of about 280 milliseconds. Everybody with me? Okay, so the atrium is beating at about 280 beats per minute. Ventricle is a little slower. And then I'm putting my grid catheter. These are all the electrograms on the grid that I'm recording. And then what I was able to find is another area of extreme continuous conduction right at the area of the mitral valve. That's where the mitral valve was connected. It's probably related to a localized scar that was created as you put the prosthetic mitral valve in that area. Typically, with circular catheters and other catheters, it's very difficult to get to a prosthetic mitral valve because you're at risk of getting entrapped in that valve. In this case, with a grid, it's relatively simpler. And this is the propagation map. I hope it plays. Oh, I guess it didn't play. Anyhow, but what we did, same thing. So the colors will, everybody knows these colors. So white is very early, purple is late, white is meeting purple, and you have the color distribution all through. That means you have the whole cycle length in that particular chamber. You identify the area where the white meets early, early meets late, where the fractionated electrograms were identified on grid. You put your ablation catheter. Again, just a couple of lesions over here, and tachycardia terminates right away. Now, again, without proper mapping, if you use just a regular ablation catheter, I would have to hunt around and probably do a full line that we used to do, extending from the left superior pulmonary vein all the way to the mitral valve. So it minimizes ablation, minimizes the amount of scar, and gets you the result that needs to be. This is an example of intracardiac echo. This is the biprosthetic. This is the prosthetic valve, and this is my ablation catheter in close proximity of where it's located. You can see it's touching the tissue. And that's why intracardiac echo is so beautiful, that you can actually see when you're not ablating inside the valve as such, causing damage to the valve. So this is the same one that I showed earlier, but a more detailed presentation of that. It's a beautiful case. It's a simple case, but a beautiful case, which will help you understand the concept of macro reentry or micro reentry, and then how we handle that, and how our ablations need to be robust when we take these patients in. The concept about first pass isolation. 62-year-old female with prior history of pulmonary vein isolation, posterior wall isolation, as I described to you. This is the ablating the pulmonary veins on both sides and the posterior wall. And now she comes in with an atypical atrial flutter. And the patient opted for ablation. Now, she was much more symptomatic with this atrial flutter as compared to atrial fibrillation. I've had patients who have had ICD shocks, obviously, from flutter and never had shock from atrial fibrillation. Just because it conducts faster in the ventricle, it's very difficult to control rate and whatnot. So again, the point being, with ablation comes responsibility. So when we do these, you got to do them right. So this is an example of the posterior wall. We used the grid and we did the mapping. You can see in a typical posterior wall isolation and pulmonary vein isolation, all of this area should be gray and scar, right? And that number of scar depends on the specific atrial tissue. And what that means is you can change this voltage criteria to whatever you want and make the color gray. But for atrium, typically, it should be in the range of around 0.1 to 0.2, okay? So if it's less than 0.1, then you know that it's really scar. But sometimes if you change it to really high, let's say 0.4, and then everybody will show a gray area in this area, but you can still have electrograms there. So anyhow, with that standard, you can see that there's some area of activation here, which is the red, and then the green, and some other signals, and going into all the way into the pulmonary veins. So clearly the pulmonary veins were reconnected in this case. Posterior wall was reconnected, and that was causing the flutter. But things were a little bit more interesting in this. This patient actually had 2 flutters going on at the same time. And again, it's very difficult to identify that with unipolar catheters or with bipolar catheters or even pen array. So if you look carefully, this is an area of scar, gray scar. So this will, if you get this diagram, you'll understand what macro reentry is. Okay? So what happens in macro reentry, reentrant tachycardia, is you have a scar, and you have an area of slow conduction in the scar, which is causing reentrant circuit to go around and causing the tachycardia. Okay? So this is called the critical isthmus. See, this is rapid conduction, slow conduction going around. And where would you ablate in this case? If this flutter is going around like this and going like this, where would you ablate? Would you ablate here? Everybody raise hands. Would you ablate here? No. Would you ablate here? Wow, that's awesome. You got it. Good. So that is the critical isthmus, right? Slow conduction. And why was that created? Was this particular patient born with it? No. It's iatrogenic because it was incomplete ablation in that area. And that caused the reentry over here and caused the flutter. So you identify that, and it's not uncommon. Sometimes it happens because the esophagus is sitting right here, and sometimes the operator has to get off to prevent the esophagus, and boom, edema gets in, and then by the time you get back in, now to give more energy, the energy doesn't get transmitted to the tissue, whatever, and then you have incomplete connections which can reconnect. So, but this is one flutter, but we can also see there's another slow conduction in this area into the pulmonary veins. You see that? So this patient has actually biatrial flutter. So you can break this, but this won't break until you get this out of the way. So this is a clear example of dual loop reentry. So one loop is running like this, and one loop is running like that. And there is no way you can get this with standard mapping or entrainment mapping. Because if you do PACE here and entrain here, you will just be able to find one circuit, but not this one, because both of them will show similar post-spacing intervals and stuff. So it's important to understand this. In this particular case, again, ablation lesions were performed in the same. This is a channel of scar in here, a couple of burns, and that took care of the problem. We also had to isolate this left-sided pulmonary veins to make it quiet as well. This is the termination, as you can see. The flutter running comes back into beautiful sinus rhythm on the coronary sinus. And then, again, I want to emphasize more on the intracardiac echo utilization. Actually, my time is up at 7:45, but the conventional, the intracardiac echo that we have available now is obviously a little bit more sophisticated than the ones we had 4 or 5 years ago. But the conventional echocardiography just use line-by-line data acquisition, and it's hardware-based, and data can get discarded. But the ViewFlex, which we typically use for these cases, is slightly different in a way that it does zone sonography. So a lot of data is gathered at the same time. This is an example of a grid catheter touching the tissue. This is one of the pulmonary veins. This is on the posterior wall. This is the same case where I ablated. I know I'm touching the tissue when I'm ablating them. And some other examples of ablation. This is, I think I already saw that. This is just right outside the right inferior pulmonary vein. You see how the tissue is getting brighter. My sheath is right here. My catheter contact is so stable, even with a moving heart. And that is the key. That is the key for these procedures, to have enough stability. This is an example of CTI that Dr. Mavroudis was talking about, a typical CTI flutter. This is the tricuspid valve. This is the inferior vena cava. This is pretty standard CTIs that we see, not too prominent eustachian ridge. So the sheath sits here pretty straight, catheter sits here, and then as you drag, you can do these ablations pretty quick. But then you run into ones which are extremely complicated with a very prominent eustachian ridge. And so you have to bend the catheter in a C loop and come around and then ablate it reversely. And this is an example of that. So summary, Advisor Grid has allowed us to create high-density maps, quickly and accurately locate atypical flutters, leading to pinpoint ablation targets and tachycardia termination. Intracardiac echo has a pivotal role, gives us another dimension in imaging modality to safety, and obviously get rid of fluoroscopy. I want to thank, I couldn't put the whole team in there, guys, so if someone follows us on Twitter, this was my tweet. There was, when I started getting through, and 1 AF ablation was an issue, and just recently we did 4, and we're done by 5:30. Complex ones, persistent, and with termination with tachycardia. I want to thank my team. I want to thank everyone. I'm going to stop here. No, this is mic 2. That's mic 1. So maybe use that.
That was a brilliant talk.
Thank you, sir.
On a rather complex subject, to be sure. I have a couple of questions. However, perhaps there are some questions in the audience that you want to engage in this rather bright fellow here who knows what he's doing.
Usman, why do you think the engineers designed the catheter like a rectangle? So the pentaray is more like just spider webs, right? And what would you think was behind the design, of the way it's shaped?
It's a beautiful question. It's a leading question. Did you know that I knew the answer to this? Okay, fine. I guess you can hear me. So this catheter originally was designed for ventricular tachycardia ablation. So especially the PAP muscles, as you get into it, so it lies flat on those PAP surfaces and gives you that activation for that. We're using for atrium because of the beauty of the grid, right? The beauty of grid is the directionality of this, but it was originally designed and as you do, if you use pen array or that spline-like catheter in the ventricle, you will see that it causes a lot of ectopy. It can get stuck in the PAP muscles and the cords and all that stuff. So it was originally, so it lies flat. And due to limitation of talk, I didn't want to bring any cases for VT ablation, but it lies beautifully on a PAP muscle when I've done the PAP muscle VT with this, yeah.
Moving a little forward therapeutically, patients, there are not very many of them, but patients over 35, into their 40s and 50s, those who have an atrial septal defect that have not been diagnosed but are diagnosed now, whether you close the ASD either surgically or with a device, the chances of atrial fibrillation in the near future in that patient approach 80%. And this is well known. Do you think that a patient who's undergoing here, let's say, who's undergoing a catheter or a transcatheter device closure of an secundum atrial septal defect, do you think that that patient ought to have a prophylactic maze that you could perform? And should that patient also have a left atrial appendage isolation? I know that's a charged question, but every operation that I do in that situation, I do a prophylactic maze, left and right, and a left atrial appendectomy.
So, you have tremendous experience in that field, but I'll be honest over here, I'm aggressive, but I'm extremely conservative at the same time. And
That's an interesting oxymoron.
Yeah.
Aggressive, but
which means that if these patients have any evidence of atrial dysrhythmias, I will ablate them. But I have to have
now they were talking about prophylactic now.
So I have to, I know. So in a patient with ASD closure or big ASD, and they have no documented atrial arrhythmia, I don't think it's justifiable personally.
George, in the last 7 years that you were able to wrestle an atrial septal defect away from me, would you do a prophylactic maze, and would you do a left atrial appendectomy?
No to the left atrial appendectomy, and probably not for the maze, using the same criteria that he had.
You have anything different to add to that, Kevin?
The only thing I would say, if they've had arrhythmias, I would have one of our colleagues look at that patient. If they've had no arrhythmias, I agree with Dr. Palmer. I wouldn't prophylactically do that because we don't do that with mitral valve surgery or other things as well, that about 30% of them have that. So I would agree. Although I think to your defense, you see a different type of patient that has had the propensity for atrial dysrhythmias throughout their childhood and lifetime, and they might not know that they had it because of their ASD.
And I would add
Well
to that.
said.
I would add to that couple things. You know, the caveats are these procedures are not perfect. I mean, with pulmonary vein isolation, even though we're doing a pretty darn good job, the success rate still ranges around 85% in the best of hands. Now, in some surgeons obviously with Pox Maze, you were getting really good results. So that's one issue, that there's chances of recurrence. You're causing an arrhythmia in a patient who never had arrhythmias. But the two bigger problem which I have seen is stiff left atrial syndrome. And what that means is when these patients come after a Cox maze, they may be in sinus rhythm with short runs of flutter, and when I go in, they have no MR, but their left atrial pressure is in the 30s or 32, which is a big problem because now you've created severe diastolic heart failure in these patients because of these randomized lines that were created. And I don't think personally they're justifiable in a patient who doesn't. Crossing an ASD closure, we've done it before, we do it. Even with device, with intracardiac echo, you can do that safely. So if a patient does develop, you can cross the septum with the ASD. I've personally done it.
Sure. Any other questions? Well, that was a brilliant talk. Hang on a second.
Kristen, how long has this been around? 2 years?
We're actually talking about people who are looking at this elsewhere.
How long have you been using this catheter, Dr. Siddiq?
Year and a half, Sarah. Almost 2 years.
Yeah. No, it seems to be, practical versus seems like, you're faster last 6 months or so. Maybe with the using, you got more time.
Oh. What she's saying is that I've been able to do more patients recently in a limited amount of time. Okay, well, thank you.
Well, that ends our grand rounds, and thank you very much for a brilliant talk.
Thank you so much. Thank you for staying awake. It's complicated, but. Thank you, sir. Very good. Hey, man, George, how are you? Good to see you. How's it going?